Hello and welcome to the EMSNation podcast. We have concluded Tactical Trauma 2019 and reassembled our expert panel to bring you the very best and highlights from our very exciting day. And a big thanks to our organizing committee who have done, an exceptional job of mobilizing a fantastic tactical operational medicine conference in Europe. So it's great raving reviews and applause. So without further ado, we're going to introduce our expert panel.
I'm Mike Klumpner. You can find me on Twitter at Mike Klumpner.
My name is Mike Gloria. I'm on Twitter at RecessPadawan.
Hi, I'm MJ Slubbert, and you can find me on Twitter at MJ Slubbert.
Hi, Leilani Doyle. You can find me on Twitter at Doyle Leilani.
Hi, I'm Mark Forrest. You can find me on Twitter at Obidot.
And Mike Abernathy, you can find me at FLTDOC1.
And there are a lot of themes of the day. And one of the themes of this podcast is we have an innumerable number of mics. Yes. So Mike Abernathy, you started out the morning as our moderator. What were some of your takeaways, reflections, and how'd you start the day off?
Oh, it was great. We had not a real late night last night. Really just started off. Good crowd. Our first up was Mike Gloria, who spoke about, what was the exact title?
The Essence of Tactical Medicine.
Essence of Tactical Medicine. And yeah, very interesting and very well received. What do you think the key points on that?
I think the key points on what I was really trying to get across in the talk is that we get preoccupied with things like individual pieces of kit, and as the TCCC and TECC guidelines continually expand, we get obsessed with protocols and we get obsessed with the way things are going in terms of sort of clinically. But overall, as things seem to morph and evolve, we go to different places. We have tactical medicine in the civilian side and the military side. I think what we missed is an overall set of guiding principles that will direct us and be sort of our tactical moral compass through adding different pieces of equipment, kit, the kind of research we need to do, how we incorporate things, and all that other stuff. And what it came down for me was for three relatively straightforward concepts that are essentially universally applicable and will drive things like individual techniques and tactics going forward.
So how would you recommend that at an organizational level or at an agency level we start to implement some of these ideas?
Yeah, so I think that the three concepts that I was trying to get across in the talk were essentially speed, simplicity, and coordination of care. In a tactical medical operation, what generally things boil down to is how you can do those three things best. And I think if you're always asking that question of how can we do those three things best, then that will eventually guide you to the correct answer in terms of training. Are we training people? Are they getting faster at what they can do? Are the times to interventions that we know that work getting faster? Are the times to definitive care faster? Or are we just delaying things? Are we making things more complicated than they need to be? If we know certain pieces of equipment don't work very well or don't work very well under tactical conditions, why are we carrying them? Why are we using them? And is everything that I'm doing actually moving toward coordinating the care that my patients need? Or is what I'm doing in terms of focusing more on interventions that are not necessarily important, not moving toward transporting the patient, not moving toward getting them toward definitive care, really what I'm doing at this point. So I think if you continually ask yourself those three questions, no matter what you're doing, no matter what you're looking to buy, no whether we're operating, no matter how you're training, if everything focuses on those three, what I think are very salient points, then I think you're always going to be led the right way.
Speed, simplicity, and coordinated care.
Yep. Speed, simplicity, and coordination of care.
That's a recurrent theme that I see is the idea of simplicity. Again, time and time again, when the shit really hits the fan, it's just doing the basics well, and that's what's going to happen. And I just saw that in several of the lectures.
Yeah, and it translates really well to civilian care as well, right? It's not just for tactical medicine. I think we find a lot of these things that came out of military experience in tactical medicine is really quite applicable to civilian EMS and in hospital care. It's very easy to make things super complicated with all of the protocols and equipment and things we produce, that when actually it's an emergency situation, what you need to do is have those three easy steps, right?
Yeah, I think the biggest thing I got from your lecture was that we're not the mission. We'd like to think we are, especially when we start to see injured patients. Oh my God, now it's medical, especially if it is, died down within the tactical context. But we're still not the mission. We're part of a bigger team, and we need to understand the tactics and movement of that bigger team and integrate within that.
I think one of the things that I wanted to sort of mention but forgot to highlight was, and I've had misinterpreted in the past, is in terms of simplicity, you have to do the basics well, and that's something I went over in there, and that those basics create the foundation for what you're trying to do. That does not mean, however, that pushing new technologies and pushing interventions into the field and out of the hospital are necessarily a bad thing. That said, when you're trying to implement them in a time-sensitive environment, if you have not refined your procedure for Reboa, if you still are planning on bringing an entire trolley full of, sterile towels and the whole 9 yards to some austere remote resuscitation area, it's not going to go very well. So you can still do advanced modalities in the field, but you still have to boil them down, train them well, be fast at them, etc. That said, as well, the corollary to the speed part is it's about speed to meaningful intervention. If you're 5 blocks from a hospital in an urban area, that means just getting them to the hospital. If you're in the middle of Africa, that may mean doing an austere damage control resuscitation, getting someone as quick as you can to an intervention where they can get transfused, or doing something like Reboa in the right settings. So it's more than just being fast and getting them to a hospital, so to speak, or being simple and just using bandages and gauze.
Now, Mike, some of the concepts that you laid out led very naturally into Mike Klumpner's talk following on medical best practices at mass casualty events.
Yeah, so I think a lot of the stuff that I follow in that talk I learned from flying on the helicopter for almost 10 years. And just because you can doesn't mean you should. And there's a huge difference. And sometimes, showing up with a bunch of really cool stuff, and like I always told people, and I learned this from my boss, Jim Mobley, a long time ago, the best treatment we were bringing to all of our patients was jet fuel. And we needed to remember that. And so that's where I've always gone back and said, we need to look at these events simplistically because they are incredibly chaotic. There's a variety of different threats when it comes to hostile mass casualty events. It's not just active shooters, it's mass stabbers, vehicles of weapon, explosive devices, chemical devices. It's the perpetrator's imagination. And so that was kind of one thing, is looking at what type of injuries we're seeing, but then looking at our practices and saying, are they evidence-based? And I think that's a simple question that we all have to ask ourselves, but unfortunately, in EMS, I think that we still are in our infancy, if you want to consider that, because EMS has really only been around since the mid-'70s, and we still feel like we have something to prove, and we can't show up to hospitals with dirty trauma patients. We've got to show up showing that we used every skill that we were taught in paramedic school, and we're literally killing patients by doing that. And we've gotten away from looking at evidence-based practices, and when we start really delving into what we do for trauma patients, there's not a lot of evidence to support some of the things that we do.
I think it was really interesting on a number of the other presentations. Take Tom Koenig with the stab wounds to the neck. I loved it when he said, sometimes I'll arrive and see the wound and say, let's go. And we're just going to pack this, put pressure on, and let's go.
And this is for the attending vascular surgeon that's responding pre-hospitally, just a primer audience.
He's going to do the definitive repair, but this is not the place, and he's keeping it really simple. And obviously we've done similar things, resuscitative hysterotomy, resuscitative thoracotomy. We've simplified them down to the absolute bare minimum that we need to do to keep this person alive. And it comes back to the John Hines, honourable intentions. Am I really making a difference, or am I just delaying definitive care, and we need to be somewhere else?
I like the idea you were saying, and what was the figure? 95% of all the mass casualty things, the standard triage
tags are never used.
They don't even use them. Mm-mm. I can remember triage tags for the last 30 years. And when it's real, doesn't make a difference. No.
Yeah.
Now, time and again.
Now, triage really got beat up during the conference.
It did.
Absolutely.
It did.
I thought one of the most salient ways to describe it is, best intentions, are really going to meet their test with first contact with the enemy. And triage and well-formulated casualty collection points and things along those lines are examples of such scenarios.
Yeah, I think we've heard it again and again from people who've been in that situation, probably as a participant or a concert goer, or and then find themselves having to be part of this medical team that Jeff actually said in yesterday as well, that sorry, triage went out of the door. And, one of our colleagues also involved in the Boston bombings, and that's what she said as well. Formal triage did not happen. It's basically, like you said, Mike, they're red or dead.
Mm-hmm.
Yeah, and another interesting point, we're taught, hey, get the walking wounded, the walkie-talkies, say, hey, come to me, and we throw them off in a corner and we forget about them. But Mike brought up the point that some of them can be extremely gravely injured, that they're basically giving themselves their own adrenaline dump, keeping themselves alive until they they're literally running for their lives, and then once they're in safety, relative safety, they lose their adrenaline dump and then subsequently die on us.
Yeah.
I'd heard about that in the Manchester bombing as well, that a lot of the patients that they thought initially were Pri 3s, Green, Charlie, whatever you want to give them, that they had to keep an eye on them because, again, these were kids. They're young. We know that they maintain their blood pressure until they die. Yeah. So if we use traditional triage, we may not have found initially the gravely injured because they compensated until they didn't.
Yeah, that picks up on another theme from yesterday on shock tolerance. Mm-hmm. And people have different thresholds for shock tolerance.
Yeah.
I actually thought one of the most interesting things that Mike brought up during the talk, well, a lot of interesting things, but was it the FDNY, a new triage mechanism, basically penetrating injuries, gunshot wounds, etc., between the clavicle and the pelvis, immediately red. Everybody else is either dead or alive.
That's it.
Right, headshot or extremities, right.
That's
the literature shows that you have a limited time to get to the hospital, so prioritizing their evac from the scene is tantamount. But now switching gears from our human patients to our canine patients, there were a tremendous amount of learning points in our breakout session with some of our law enforcement officers and the medical care related to our canine partners.
The canine session was really, really good. It was different. It gave a whole different perspective to things in several ways. One, in terms of they very rarely would be our priority. There's human beings here dying. But then if this is your partner that you work with every day, that makes no difference. This is your partner. And hearing the guys who work with these dogs on a day-to-day basis, and they're going to do their absolute utmost. And then it got down to the practicalities of, even if you do work with this dog and it's your best buddy, he's not going to be your best buddy when he's shot, when he's injured, he's in pain. And so muzzling early is obviously so important, just to protect everyone, including the handler. And then other simple practical things like tourniquets won't work on a dog. A windlass tourniquet, because of the plastic strip, will not fit around the leg. And then I never realised that dogs have a fenestrated mediastinum, and it's basically one chest cavity. So if you get a tension in pneumothorax one side, you're going to have it the other side too.
So let's just pause there. There's so much to take away. So one, situational awareness, right? With your canine colleagues, even though they're your best friends, muzzling them early if they're injured is of tantamount importance. Now, our anesthetist consultant, for our EMS audience, can you help explain the pathophysiology? So a dog or a canine has a fenestrated mediastinum. So what are the implications for tension pneumothorax? Help us understand that a little bit better.
Yeah, I think it's like what Mark said. The chest cavity is actually not like in a human divided in two. So if we get an injury on one side, whether it's blunt or a penetrating injury, we can get a collapsed lung, pneumothorax on that side. And if it becomes under tension, then, all of our blood vessels and our heart and everything gets compressed. But it does move over a little bit. So I assume we have a little bit more time than a canine who has one chest cavity. So even if they get a unilateral stab or anything, both sides of their chest, their lungs collapse and they start filling up, and I assume their heart just gets squashed in the middle.
Yeah, you think from both sides.
So, but hopefully the good thing about it is you can make a finger thoracostomy or put in a chest tube on either side, and you should fix both sides' problem.
Yeah, so the obstructive shock can be worse with tamponade facility or tension pneumonia
faster as well. Yeah,
they're immediately going to have no lungs, whereas we might function on one lung. If we're dealing with a simple pneumothorax, they're going to have two. straight away.
Now, how about pain control for our canine colleagues? A little bit different than for humans.
Yeah, I think we were all quite surprised when ketamine took a hit. You know,
Ah.
we always see
Not the Swiss Army knife.
the magic bullet. Yeah, so that was very interesting. The ketamine is not the analgesic of choice because of hypertonus and agitation and salivation. And in fact, morphine IM, quite high dose with a typical Alsatian, a large animal, 30 milligrams to 50 milligrams IM was the dosage recommended.
But it's still okay if your cat is your partner, right? Ketamine's okay for cats. So.
Tactical cats.
Yeah.
Are we talking,
I'm totally for that.
are we talking lion or are we talking...
One of the issues that we're having to deal with in the States is it is a felony in most states to provide advanced life support care to animals. If you are not a veterinarian, you will go to jail.
That's really interesting because, again, I operate an animal shelter and with my wife, and over the years I do quite a bit of veterinary care. But yeah, it's right.
Yep.
I think, just having recently taken my pre-hospital board exams, so the definition of licensure is when the state allows you to do things which otherwise would be illegal. So typically what we do or perform on a regular basis may be considered assault when I'm sticking tubes into places where they don't normally belong.
Or fingers.
Or fingers, yeah. So on that parallel to animals, our training not necessarily is on veterinary care. So
Right.
I appreciate that despite the best intentions.
Had to put that disclaimer in there for our folks. But I mean, they are working to change laws in states to allow EMS providers who have had basic veterinary care to be able to perform. Endotracheal intubation in dogs is very easy, and some other things. So,
and doing the basics, like giving them a bit of oxygen.
and you
if they've
can
been
do
trapped
that.
In a fire,
You can do that. But once you do anything advanced life support, then you're practicing veterinary medicine without a license.
I love the converse, though, that because vets can treat us.
Well, but plus the idea too that this care rendered in the field, certainly if there's no other human victims, and is attached to animals as people are. Again, they think partner. This dog's an officer, and all that. Again, they are animals, and human beings should and always have priority. But in the case of isolated injured, or you have enough resources, absolutely, you're going to take care of this animal.
One thing I want to add real quick, there was a really cool lesson that I learned from a active shooter event that we had in North Carolina. The tactical medics immediately deployed. They got the kiddie pools from our hazmat trucks and filled them with ice and water. And it was because we were running so many bomb dogs through the buildings that they would have the dogs come out and lay in the ice pool for about 5 or 10 minutes. Because if a dog's panting, he's not sensing any explosives. So as soon as they came out, they got iced down, and then they got put back in play. And so some tactical medic had heard about it and it worked.
So
it was
that
magic.
is an absolute direct parallel to firefighter rehabilitation, which is of course a normal part of our practice. Interesting.
Can't function when you're overheated.
Yeah. Now, I love when we always dig into the psychosocial aspects of providing medical care. So we had some interesting points about anger related to caring for our own patients, as well as some interesting learning points about PTSD.
Yeah, so I think Ville brought up the point that it's natural and normal, and it doesn't make you a bad person to feel anger, downright hostility towards your patient, especially if they are a bad person, they've done something terrible, they're a terrorist, or they're the person who assaulted someone else or killed someone else. That's okay for you to have that reaction, to accept it, and then just kind of get on with being a professional and giving care, but not to beat yourself up over it.
Yeah, I think we all sometimes suffer from empathy fatigue, and that's been described as well, like when you're tired, when it's overwhelming, or even when it's very, very quiet, that lull in your concentration as well. So I think, like you say, it's recognizing it in yourself, but also staying professional then.
Yeah, Ville is one of our Finnish anesthetists, and he's a big hunter as well. So I appreciate that he brought up that emotional components of care. Now, Dr. Ishay Ostfeld is Special Operation Forces Director, Medical Director for the IDF, operating out of Tel Aviv. Now, he had some interesting learning points related to PTSD.
I enjoyed his presentation. I mean, he was amazing in 2017, so I was looking forward to it. And he sort of landed running again with really good quality data. But some of his latest research has been around PTSD. He was talking about the resilience of Israeli people in the face of ongoing terrorism and threat. And he was saying the way they've set up 9 centres around the country that provide immediate social and psychometric care to victims. But then when they've been looking at some of the data and the incidence of PTSD that's followed some kind of acute stress, he was really shocked, and he couldn't give an explanation. And this is about to be published, and I think he's looking for suggestions. But he found that those with minor injuries, if they had early support, actually got worse PTSD, and it was as high as 30% in those with minor injury, which really shocked everybody, because in the more severely injured, it didn't seem to be quite as bad, and in the ones with no injuries that just presented at the centre, it was certainly helpful. So that raised lots of questions about counselling and that kind of support early, which I think some of us have doubted in the past.
I think we've found the same exact thing in American society, where everyone thought it would be a good idea to have mandatory critical incident stress management, CISM or CISD. Part and parcel of that process, or one of the learning points, is that yes, it can be helpful, but should always be voluntary. Absolutely. In other words, if the victim is interested and seeking that sort of support or care, that it may be a benefit for them, but mandating it, in fact, can cause harm. How do you guys deal with your crews after a tough call? We have a number of medical directors and field supervisors here. After a tough call, what are some of the best practices that you have for, discussing
Got to start with
that?
the hot debrief. I think that's always important.
Well,
It
hot
may not
wash.
tackle all the issues, but checking everybody's safe, everybody feels okay, if there's any immediate issues. But then I think for the big job, you've got to follow that up.
Yeah, I think in England it usually helps having a cup of tea in the hand, sitting back at base, making sure everybody has had a wee and everybody's eaten something and is ready for the next job. Because the last thing you really want is to be halfway through a hot debrief and you get this next shout and nothing's ready, and now you add sort of to the chaos.
Adrenaline pump, yeah. So maybe even taking the crew out of service for some time.
Yeah, absolutely. Yeah, having been through, I tell you, we had a fatal crash in my program in 2008 in dealing with, again, the mandatory stress debriefing versus all that. And I think Christina Hernan brought it up after her experience with the Boston bombing. Probably the best thing is to be able to be with people who know what who have gone through the same thing and are going through the same emotions. And that was the most valuable thing, I think, is just hanging out with the rest of my crew and spending time for several days. It was far, far more valuable. The formal debriefing, the vendors sent in people and psychologists and all that, and it was useless. So just spending time talking about it.
One of the things that I learned at the helicopter after a bad call, I would call one of my physician friends who had nothing to do with the helicopter and run through the call and let him objectively tell me if I did right or wrong. And I couldn't approach my own medical director because then, things could have gotten punitive. And so I guess if you have a service and you have an assistant medical director, if the person utilizes them, then they're out of the QA/QI process. And you can do that. And one of the other things I want to mention about PTSD that we're finding with these active shooter events and why it's so important to get people out is the longer people stay, even if they're uninjured and they're on lockdown, it is developing PTSD because they are in the worst moments of their lives, still in the absolute terror location. And the sooner we can get them out and get them into areas of relative safety. So you have 15 little ones locked down in a closet with a teacher who's telling them that I'm your best friend and maybe someday you'll see your parents alive. The sooner we can get them outside, the sooner we can stop that. And the only other thing I'll say is we have good data that's coming out right now that lockdowns are causing PTSD in our little ones. And we are using lockdowns way, way, way too much. And so it's absolutely, we're having kids writing last wills and testaments and all kinds of stuff.
Shooter drills also?
Yes.
Type of
Well,
thing?
so no, these are preventative lockdowns. So this is just like police are chasing someone 2 miles away. The school's going to go on lockdown. So they go on lockdown. Everyone hides, and they're hiding for 2 hours. And we're having case after case after case where this is creating just destructive trauma in kids. And there was one of my friends, a forensic psychiatrist, and he had a kid referred to him who was 8 years old and was starting to bedwet a lot. And the GP referred him, and he talked to the kid, and finally after 4 sessions, the kid revealed to him that he was worried that the lockdown would come and kill his parents at night. And so he didn't understand why they were doing lockdowns, but he was worried the lockdown was going to come and kill his parents. And so we've got to be careful because sometimes the best of intentions are causing untoward consequences. And now we've been doing this long enough that we have the data showing that we're doing this way too much.
Wow.
Yeah, two important points that I wanted to harp on is the concepts of just culture and a culture of safety. So a lot of services are adopting the model of a culture of safety where even if you have an error, if you in good faith report it, there's non-punitive. And, really the best approach as a medical director or a field supervisor is to look at the system. How can I make certain system level changes to try and prevent or preclude this from happening? Actually disclosing that a medical error occurred to the patient and apologizing for it, I think are, not so revolutionary concepts, which we're just starting to employ with greater effect. Because, of course, we're humans and providers ourselves.
I did a lot of expert malpractice work for critical care transport, and I'm sure Mike has too. And when you look at everything at face value, it always looks like it's human error. But probably about 90% of the time, it's an organizational cultural error that led to mistakes. Yeah. Yes, they were led into a position to make a bad decision. People don't just arbitrarily make bad decisions. So typically, it always points back to organizational culture.
It's allowing people to hold their hand up, though, isn't it? I mean, we know pilots can do it. They declare a mistake, and then they're relatively immune from prosecution within reason. Mm-hmm. And the fact that we need to be the same. People need to not fear holding the hand up and going, "I screwed up," and this is what happened, and this is what I've done, and then go through the reflection and the learning and everything.
Well, the only other thing I would put to that is hospitals in the United States, when you declare a mistake, it's non-discoverable in litigation. But for EMS services, there are no laws that prevent that. Right. If you're a non-hospital-based helicopter service and you declare that you gave the wrong medicine, that is completely discoverable. In one sense, we're very litigious in the United States, and so there's almost a culture to not report because it sets you up for litigation failure. So if we could get laws in place that say if you make a mistake that it'll save you from discovery at least, then we would see that. Hospitals have it, we just haven't done it.
Yeah, and so one of the interesting sequelae from that is hospital-based EMS systems actually have increased protections because they're thought of as an extension of the hospital. True. So the next phase of our afternoon dealt with a whole host of specific injury types and patterns. And that was penetrating trauma, including knives, stabbings, and neck injuries by Dr. Tom Koenig from the UK. Tactical medicine in mass casualty events, that was Dr. Matthew Langlois, who was actually one of the physicians, who's a sworn officer within the RAID, R-A-I-D, who responded to the Bataclan and Parisian attacks several years ago. We had obstetric traumas and hysterectomies, as well as blast injuries. What are some of the takeaways that you guys have from that set of lectures?
Well, the one that I found fascinating, because we've always talked about resuscitative hysterotomies. I know in the United States, so I wasn't aware in Finland that they had two successful. Now, they weren't traumatic arrests. I believe in both cases it was a medical arrest of the mother with some delay, because they always taught, in trauma you have 5 minutes or so. Four or 5 minutes. Yeah. And these were 20 minutes, and yet these children survived intact. They were born premature and under very austere conditions. But, it's like, wow, so this is real.
I was really impressed that she managed to make a top cover call and get a response from an obstetrician. All credit to the obstetrician for just do it. Because I don't think we'd get that response.
No. But equally, what she mentioned brings us back to you can do advanced procedures and simplify them right down. Because in her talk she said, we didn't have much. We had a scalpel, our hands, and some cord clips. So, and it's the same when we think of advanced procedures like pre-hospital thoracotomies, right? You have very little equipment and you do a very advanced procedure. And again, it cycles back right to what Mike was talking about in his lecture as well.
And so just a clarifying point here. So this is under the Franco-German model of EMS. So these are pre-hospital physicians who are responding to these advanced procedures.
That's right, yeah. I thought the afternoon was amazing. Because I had the opportunity to also in detail, because I was moderating, to read through the CVs and things of these people, and I Googled most of them as well. And it's really incredible the type of speakers and the quality of speakers that this conference attracted. I mean, they're all sitting in the room here with at the moment, but it was
the hysterotomy was amazing, wasn't it? Because at the time, she'd never done one before. You could clearly see the emotion there when she was describing the case. And we have to say that the mother had a non-survivable injury.
And the bleeding. injury, a massive aortic.
Yeah, I'm interested to read the paper. They
Yeah.
did publish the case of 2, so yeah.
Yeah, we'll work to link to that in the show notes as well. But it's a once in a lifetime, once in a career procedure, if that.
The thing that struck
Twice
me
in
about
Finland
that,
in a year.
was the decision gap. So going from knowing that you need to make a critical procedure to actually making the critical procedure, and here you have a physician responding who got correlation and confidence from an OB physician.
Yeah.
And so now you have to go back and look at all your other providers who do an ultra low frequency, ultra high risk procedure, and what is the interval gap that they go through. We see it in surgical crikes all the time. Sometimes we crike patients way too late, and instead of, how can we shorten that decision-making process up, whether it's through high-fidelity simulation, whatever it is. So she was doing a once-in-a-lifetime procedure, and she's a physician and still got reassurance from another physician. And so that was what kind of struck me is, what ultra-low processes do I do that need to be done right now that, I still want to get everyone in the room to shake their head yes and say, this is what we need to do.
That's going to be a very, very quick call.
Yeah.
You're not going to be hanging on that phone. And that's the thing. So the person on the other end has just got to get exactly where you are and exactly what you're faced with and give you an immediate yes or no.
But you see, that's why, I'm maybe a little bit biased with the, British style of EMS, where the medical directors, actually all of them have clinical experience. They've been in the ditch with the people, and they know exactly, like Mark says, if that phone call comes in, they know what situation you're in, and that's why they can quickly say. And even very advanced pre-hospital care systems like London's Air Ambulance still has that sort of model. If it's a junior, someone who's just starting, or it's a resident, they have a quick phone call to the consultant, especially in some specific procedures. And like you say, it might just be, it's never really asking permission, but it's having that confirmation and knowing that someone you're talking to actually knows where you are and what you're going through.
Yeah, that supportive environment is definitely clutch, especially before you're about to embark on a procedure you may not have practiced that often.
One thing that she did mention was that this is obviously a procedure to save mum first and foremost.
Great point.
And then possibly for baby. But in another podcast I'd listened to where resuscitative hysterotomy was done, a lot of people in the room, I guess, were unaware that this was not, the reasons for it being done, that it was not for baby, that it was to save mom, and they were fairly distraught when baby was taken out and clearly unsurvivable, far too premature, that nothing was done for the baby. And so they were just completely taken aback by that. So if any of your listeners are ever involved in it or doing one, a quick, this is to save mom, this is not for baby. We will try to if the baby is at a certain age. However, our primary goal and our primary patient is mom.
What did she say? Removing baby increases cardiac output by 60 to 80%.
Yeah, it's ridiculous.
Effectively, the mum is not resuscitatable, which has got a baby of that gestation still in situ. So if you don't deliver the baby, you're not going to resuscitate mum.
Because the placental bed is a low flow bed, right? And immediately once you remove that with the baby, you have, that bed is removed, and you actually auto-transfuse probably the mum as well.
And I think that's the key thing with hysterotomy and thoracotomy. I think we've now reached the point where it's crystal clear when you should do it. There's still some grey areas, but there's these crystal clear areas. And I think where you may still want to do top cover is something like an amputation, for example, where there may be still an alternative approach or something, and that's where top cover can be useful to maybe have more of a discussion rather than a yes-no.
And by top cover, you're referring to just a conversation with your commanding officer?
Yeah. And as MJ says, it's got to be someone who gets it, someone who understands where you are and what you're dealing with.
Now, what about blast injuries, penetrating traumas? Any additional takeaways there?
They were all really good, weren't they? I mean, as
great
we said
reviews.
earlier, Tom's session on the stabbings in the neck was
Good
just,
review of anatomy.
Yeah, it was a masterclass from a master. I mean, it was just really, really good.
Yeah.
Very straightforward, very simple, which is what we need because we're not trauma surgeons. But also making it clear that you can make a difference in this area we all fear. Your stabbings in the neck are terrifying. Yeah. What's it called? Tiger country.
Yeah, absolutely.
But the bottom line was still get them off the X. get them to the hospital. Even if you were a trained surgeon, you're not doing things for them in the field. You need to get them to the hospital, to an operating room, where they can get definitive care.
Yeah, and he showed a blood gas of a patient that was
6.4.
Yeah, he was
I mean, it looked like if you showed that in an exam to anyone, they'd say this is unsurvivable.
Yeah.
Yeah.
But I think
It's
that just
cadaveric, yeah.
that just shows how young trauma patients compensate and and survive if you do the right things for them.
I think Dr. Langlois' talk and development since the Bataclan raid on really moving patients off the X or out of the hot zone or out of the warm zone has been fantastic work, since they do have, tactical medics and physicians who are deploying. It was a theme that was highlighted over and over again yesterday, whether you call it the disaster gap or the therapeutic vacuum. The delay that is inherent in treating these potentially preventable deaths in the warm zone is really something as a society and American European model, we need to figure out a better way to do it.
I love the way he describes the doctor as the flow facilitator. Anyone can put a tourniquet on, anyone can do it. But it was the fact that you're there to make the decision. So you're bringing your experience, whether it's the triage process, they go first, how they're going. That was really powerful. It's always great to hear his description of things. And it's an amazing system they've got set up.
And then in the last bit of the sessions in the afternoon, my good friend Knut Taxbro is also an anesthetist out of Norway and Sweden, did a brilliant review on burn care. And one of the things that has been a recent learning point for me is it's one of those pendulum swinging issues where we are always emphasized you need to secure the patient's airway before anything catastrophic happens. And we're now learning that we're likely over-intubating burn patients with some associated harm.
Yeah, that's something near and dear to my heart. I really have studied burns and pre-hospital care of burns. And yes, in the United States at least, we see intubation of people who have had flash burns. Yes, they have carbonaceous sputum and they've singed nasal hair and all that, but they're talking and everything. And I've seen things go wrong with a normal intubation. So I guess in what he brought up, certainly if it's an anesthetist or a controlled hospital environment and you're going to intubate them, typically no harm, no foul. But if it is in the field, depending on the experience and training of the paramedic in the field, this is in the U.S., things could go terribly wrong. So
it's a very hard thing to write guidance for, though. I'm sure many of us have tried, and I think that the fear of getting it wrong and missing the patient that comes in with the swollen airway. But I think if you aren't going to intubate, well, at the very least get some nasal airways in, get some kind of airway protection that we can then work with. It gives us something to work with anaesthetically when they come in. But he showed several sets of guidelines there, and they were all good. But they were all different.
Right. The Denver, and the idea of eschorotomies, too, he was talking about. So, eschorotomies rarely, need to be performed before 6 to 8 hours after injury. Circumferential burns and with fluid resuscitation, yes, you can get swelling and compartment syndrome. There are some cases where they need to be performed early, but a lot of the studies show that eschorotomies performed outside of a burn center are often done incorrectly and incompletely.
Yeah, burns it's like you say, Mark, it's one of those tricky things, do you give them fluid? Don't you give them fluid? Do you intubate them? Don't you intubate them? Do you cool them down? Do you prevent hypothermia? And I think because, single stab to the chest is pretty predictable what's going to happen there, but burns are this almost evolving thing. Whatever you do, you can either make them worse or you can potentially make them better. So it is tricky to write guidelines for.
Yeah.
And like many things, burns care in hospital is being so regionalized in most places. I'm not sure if it's the same in America.
Same.
But it's in Canada,
it's ridiculous.
it's in the UK. So a lot of people, even in hospital, don't have that expertise to deal with burns.
General surgeons used to take care of, just non-significant burns, 5-10%. Now, almost any burn, I tell you, is referred to the burn center for definitive care.
Certainly in the UK, it's improved our outcomes. There's some amazing survivors now.
Especially if
specialist burn centers.
Head and neck related to overlying any joint, if it's circumferential.
Oh, yeah.
Hands
Children.
are a big thing.
Hands and
for
feet,
function
yeah,
and disability.
Yeah,
Yeah.
and major burns, yeah.
All right, last but not least, I had the privilege of talking about a novel concept which my colleague Mike actually introduced me to at the World Trauma Symposium. But the use of vehicles as weapons of mass destruction has very unfortunately become increasingly common as a mode of attack, both domestically in the US as well as certainly in Europe, as we've seen through propaganda magazines. Anybody can go out and rent a large truck or a cargo carrying van, and the formula that we have to remember is kinetic energy equals 1/2 mass times velocity squared. So if you have a heavy vehicle and have a distant traveling speed, your potential for doing significant damage as a lone wolf can be tragic.
I think you brought that home so well in terms of this is so accessible, minimal preparation. They can, as you said, they can almost go down to the local hire place and just pick their vehicle and pick their weapon. And then the video you showed at the beginning, obviously it was a simulation, but it just highlighted to all of us how many casualties you're suddenly going to be faced with and spread over such a long distance, and how daunting that can be.
Oh yeah, and as a human being, I find it quite disconcerting, right? You don't need to be close to people who like guns or fires, or there's cars everywhere. Especially traveling, you're very often in unknown pedestrian areas, and it's not a historic thing. We had one of the presentations that was just from August in Barcelona. It's quite frightening, I think, but equally, giving into the fear is probably not the way to go, but seeing how we can deal with these things. And I'm sure, the governmental agencies and the tactical teams and things are looking at things. Like, I was thinking, maybe they can have an EMS pulse that just stops it. Yeah, so Star Trek sort of things. But
yeah, but that's truly, in fact, in development.
Yeah,
So some of the solutions.
see, they should have just asked me. I could have said
There you go.
Well, just think,
EMS pulse machine. Yeah.
just think about it. With any other terrorist thing, if they're building bombs or amassing ammunition, so they have to be very secretive and they have to worry about it. And most of these guys they're going to be taken out, they're going to be dead. But their mission could be compromised. But unlike that, anyone can rent a big truck. And
What I learned that I'm definitely going to take home with me as a trauma team lead to my center is, Mike talked about it too, basically when it's intentional motor vehicle and intentional mass casualty shootings, that the patients are much more injured than just, I go out, I'm at a particular person, shoot them, or I accidentally hit a pedestrian. That the pattern of injury is different, that the ISS is much more severe, and I hadn't really thought of that, and I wouldn't have necessarily prepared for that.
It's incredible we have the literature on these. It's unfortunate that they've become so common that we actually have retrospective meta-analyses looking at the injury patterns from intentional vehicular assault. And again, indeed, the ISS scores are significantly higher in those patients' populations compared to an incidental, non-intentional pedestrian struck.
Yeah, because people normally probably try and brake,
Deceleration.
Yeah, deceleration. It's not really how hard you get hit, it's how fast you stop, right? So that's that impact at speed that really gets you.
And the logistics of this type of scene are so complex and something that we do not routinely prepare for. So, of course, when we think of MCI, okay, I'm setting up command, I'm going to be the incident commander, I'm dispatching all these additional resources, just tell me where to go. But what happens when your scene is over 1 mile long? Where exactly are you dispatching your ambulances? Is the scene safe? How exactly are you going to deploy your resources? It's such a complex thing to deal with, especially if you get into areas where, what we call soft targets, where pedestrians can really essentially be mowed down.
I love that comment that you made about if you're making a pedestrianised area, make it truly safe and pedestrianised, and just a few concrete blocks doesn't do it, a few big boulders doesn't do it. I mean, that was really important, because you see them and you think, I'm pretty safe here, but clearly you're not against a vehicle of that size with that much energy.
I think the other thing you have to look at is when you're going to something like Las Ramblas, I'm sure just about everyone here has probably been to Barcelona, so there's a lot of people there already. And so when you go to Bastille Day, there's a lot of people. So you're looking at an incident that's spread over a mile in Nice and over, a quarter mile or so at Las Ramblas. So you're trying to get resources in, but you have tens of thousands of people who are already there. Right. And so not only are you trying to get your resources in, but you have massive crowd management that you have to deal with. And like the theme has been from all of this is, where's the second attack coming from? Where's the third attack coming from? Where's the fourth attack? And I think he went over that in Barcelona about their vehicles staging right next to the attacker's vehicle, and trying to keep in mind that, first of all, do we recognize that this is a terrorist attack, or is this a drunk driver, or is this an elderly driver? Is this
event,
is this some accidental? And none of us want to recognize that it's a terrorist event right away. And by the time we do, we realize that we've staged all of our resources and assets right on top of the problem.
Thinking of all of these events, all of the mass casualty events as well, you have to also think about those spontaneous responders, the people who are in the crowd who's then suddenly faced with people all around them dying. And some of them want to help, but some of them might be scared or might not know what to do. And that comes back to the totally uninjured people who also suffer these consequences. And you made a good comment, Mike, in some of our discussions afterwards about, the relationship that you have with the injured person can maybe affect how you as a spontaneous responder respond, right? And I always wonder if there's not an opportunity there to, help the general public as these things become more and more common, to just be comfortable in offering almost buddy help, And I know the Stop the Bleeding campaigns have really tried to do some of that, but I'm wondering if there isn't that first chain link in survival that we cannot help as medical professionals probably buff up or lift up.
I think that's what I took away from the Las Vegas one is, more than 70 off-duty law enforcement, fire, EMS, and military personnel stayed and became, I don't want to use the word secondary responders, but became secondary responders. And so you almost have to look at that in your planning as having a deputy incident commander manage your resources who are there and are trained, and you can put them to work very, very effectively. Maybe you're another resource commander's, working with your citizen bystanders, but you're going to have a lot of off-duty people who are coming to help. And obviously we can learn from our Israeli colleagues about how they kind of manage this, but we see this a lot, and we need to manage it and be effective at managing it.
Because they are there. They are hands there. They're not people that have to come from far away. Because I think what I took from a lot of these is that in these sort of mass casualty events, medical help is coming, but it can take up to half an hour sometimes for them to just be there and to evacuate the first casualties. And I thought if you're ever in that situation where you're shot or stabbed or you're in one of these events, you must feel totally helpless, right? Because people are coming, but it feels like it's taking ages for them to get there. And when you read back on some of the testimonies of the 7/7 bombings and things like that, that's always what people recall. It's like, why did we wait so long? Where were the people coming from? And there are many people still able to help. And I think it's like you say, managing that and trying to empower that somehow.
I think that's a really key thing. I mean, it's so easy for us to get so excited about hysterotomy and all these other things, but and just training the public in some really simple things is not very exciting, and yet look at cardiac resuscitation, look at Seattle and now the bystander CPR, amazing.
Yeah, and the Good Sam app and things, mobilizing people.
And the resource is there and people want to help. They're not all running away, and as you say, they're already there. It's going to be a long time before the professionals turn up. So I think we've got a duty to train people and get them and give them the skills and empower them to help.
I think the biggest word you said is helplessness, and we've got to get that word away. So make sure the community and everyone there doesn't feel helpless in these situations. They know what to do. They know how to be helpers to us. And so once it's the old go boil water and get me some towels for the husband, when his wife is, do something, and all of a sudden, they have a mission, they have a task, they're empowered, and they're no longer a victim, they're now a survivor, and there's a huge difference.
Absolutely.
Well said. And I think just to put the finishing touches on the podcast in terms of next steps, empowering and preparing our communities further and just teaching simple, basic skills can be incredibly life-saving. But then also working together as an international community to discuss these issues and challenges that we're all facing now, and to work cohesively and in concert to try and mitigate these threats, which unfortunately are becoming increasingly paramount in modern day society. And with that, This is Mike Klumpner, Mike Loria, MJ Slabbert, Lilani Doyle, Mark Forrest, Mike Abernathy, and Faison Arshad wishing everyone a safe tour.